Hi, everyone. Thank you for joining myself, Abby Sassaman, and Courtney Studwell today for Elements of a Genetic Counseling Session.
So first we wanted to briefly introduce ourselves. So I'm Courtney and I'm a genetic counselor at Brigham and Women's Hospital, both in the clinical laboratory, but also in the Center for Fetal Medicine and Reproductive Genetics. And the way that I found genetic counseling was through a family friend who had 2 children with a rare genetic condition. And they shared their experience of working with a genetic counselor with me. And they really focused on how genetic counselors were these compassionate healthcare workers who had this expertise, but were also really good at working with patients. And that really appealed to me as someone who was really into genetics, but wanted to work with people as well. And so I pursued a degree in diagnostic genetic sciences from the University of Connecticut, which is a program that trains students to enter the field as lab technologists in genetics laboratories, whether that is cytogenetics or molecular diagnostics. And so I was trained in a lot of the technical hands-on work that goes into the laboratory, and then transitioned more to the clinical side when I went to school for genetic counseling. And so upon graduating, I started working at Brigham, and I am there today in the laboratory, as I mentioned, most of the time.
All right. And again, I'm Abby, and my path was a little different to genetic counseling, but love to give you a background. I graduated from UC Berkeley with a major in biology and a minor in global poverty and practice, where this really mirrored my interest in science with my interest in providing equitable access to medical care for patients. So a lot of my work there was with the homeless population of the Bay Area. But after school, I was really unsure where to place those interests. So I found myself at a genetic testing laboratory where I participated in roles in insurance billing and account management. And through that, I discovered genetic counseling and really the unique skill set that genetic counselors have, both in a clinical as well as a non-clinical space. And so through that, I was inspired to go through with a genetic counseling career. And so my transition is from an industry or a non-clinical capacity to clinic. And I am on the Brigham and Women's prenatal and reproductive team, along with Courtney, who's there one day a week, but we collaborate often when she's over in the laboratory. And I really feel that this is helping me utilize the unique genetic counseling skill sets to provide equitable access to all patients in a clinical setting. So that certainly is the goal, and we will go ahead and talk more about what those sessions look like. First, though, I do want to highlight the interdisciplinary counseling that we do at Brigham and Women's. So from our prenatal and reproductive roles here, we are really working with a high-risk obstetrics team, as well as infertility and preconception. So that's why we have the prenatal and reproductive genetics. We are also collaborating with cytogenetics and molecular genetics laboratories. But we don't stop there. There are so many different genetic counselors and different specialties throughout Brigham and Women's Hospital, as well as Boston, whether that's research, clinic, more business, insurance. There's a lot of different roles for genetic counselors. We're going to be specifically highlighting today the elements of a genetic counseling session. So I want to first start off with what the patient experience is like. And with a lot of the genetic counseling conversations, not just in a prenatal capacity, but other specialties as well, you're often having really difficult discussions with patients, delivering hard news, whether it's a genetic anomaly thought to be the cause of ultrasound findings, or perhaps a known cancer mutation in a family. Really having those difficult discussions incorporates both the counseling and the genetics part of our profession. Along with those difficult news, we're also providing empowering information to patients as well. So really both sides of the spectrum, really empowering people of what their information means to their family, what they can do with that information, really helping patients take ownership of their genetics through their own understanding.
So like Abby mentioned, there are genetic counselors that practice in all different specialties, whether it's prenatal like we do or in a cancer or pediatric setting. But regardless of the setting, there are some common goals to a genetic counseling session. And most of these goals are to help a patient understand genetic conditions and the risks associated with their family history or the testing that they've had. And with that comes discussing testing options, going through what are the benefits and the limitations of those testing options, what does that mean for their family specifically, and then helping facilitate that decision making. And genetic counseling is traditionally a non-directive career in the sense that our counseling is not based on strong recommendations about what a family should do, but rather providing information and helping a family come to their own decision about what is the best decision in terms of genetic testing for them at that point in time. So the first thing we do when we have a patient coming to see us is we do some background work so that we know we are 100% prepared or as prepared as possible when we are seeing that patient. And so that involves digging through some of the medical record, looking at the patient's history, if there's anything that pops out in that medical record, researching what possible causes of genetic conditions there may be, or thinking about what could be due to genetics in their family history. Part of it is identifying patient resources before we see the patient so that we have materials for them if they are needed. And we always want to formulate a plan for the session to make sure that we are covering everything that needs to be covered and have an idea about where our conversation might go. So to show how we do some of this background work, we have an example referral reason. So this might be a patient that we would see in our clinic, a 37-year-old woman who's currently 11 weeks pregnant in the first trimester, and she has positive expanded carrier screening. So when looking at this indication, we get a little bit of information, but there are definitely some things that we would want to look into, especially in the medical record before seeing them. So one of the pieces of information that we might be able to gather is looking at the screening that this individual had. And so for context, expanded carrier screening is screening that we offer to individuals who are pregnant or planning a pregnancy in the future. And essentially it's a genetic test looking to see if an individual is a carrier of any number of conditions that could be anywhere from 100 to 500 or more. And most of these conditions are inherited in a recessive pattern, which means that we require 2 non-working copies of the gene to be affected by that condition. And so what we do is we start with a patient, see if they're a carrier of a condition, and then go to their partner to see if they're also a carrier. And we know that if they are both a carrier of the same condition, there's a 25% risk for a pregnancy or for any future children to develop that specific condition. So looking at the top part of this report, you can see that this is the results for the patient and that she was identified to be a carrier of 3 different conditions. And when we get this positive result, we tested the husband, and he was unfortunately also a carrier for one of the same conditions, which is Smith-Lemli Opitz syndrome. So in our preparation, we can look at these results and see what specific mutations they have that are making them a carrier of these conditions. We can assume that most of our conversation is probably going to be about Smith-Lemli Opitz syndrome. And we also know that their current pregnancy faces that 25% risk. So these are all pieces of information that we are gathering from this report. And so for the session, we want to make sure that we have accurate information about Smith-Lemli Opitz syndrome so that we can communicate that to a family and paint a picture for what this condition looks like in a pregnancy or in a child. And so, like I mentioned, it's an autosomal recessive condition that's caused by 2 mutations in the DHCR7 gene, which codes for an enzyme that's responsible for cells' production of cholesterol, which is really important in a bunch of different organ systems. So when pregnancies are affected with this or a child's affected with this, they can have multiple anomalies of many different organ systems, and it can cause fetal, neonatal, or childhood death. And so some other relevant information here, you can see that the incidence is pretty rare, 1 in 20,000 to 1 in 40,000. And there's different likelihoods of people being carriers of these conditions based on what their ethnicity is. And as I mentioned, that there can be multiple differences in multiple organ systems associated with this condition. Some examples of those could be microcephaly or a small head size, holoprosencephaly, failure of the lobes of the brain to divide into 2 different lobes, and as well as other brain anomalies, cleft palate, cardiac anomalies, kidney anomalies. Ambiguous genitalia is something we can see on ultrasound. And a sign that we see a lot in these patients is 2-3 toe syndactyly, so fusion of the second and third toes of the feet. So I verbally explained autosomal recessive inheritance, but when we're thinking about preparing for a session, we often want to identify patient education tools like this one that can help us explain this in a way that's understandable to maybe someone who hasn't taken a genetics course or who hasn't heard of autosomal recessive inheritance before. So this really is a tool for us to most appropriately convey the information that a patient needs to understand their test results and understand their risks.
All right, so we've done our homework. We understand what the referral reason is, why we're going to talk to the patient, more about the condition. Now the patient walks through the door and it's time for contracting, which is really starts with establishing rapport with verbal as well as nonverbal interaction. And then importantly, developing a genetic counseling agenda with the patient. Different patients are going to react to the same type of referral reason. For example, the carrier for Smith-Lemli Opitz very differently, and it's our responsibility to tailor the session to our unique patient. So it's important to elicit their concerns, expectations, and perceptions, and better understand their knowledge base. Where is the patient coming from? What's their understanding of the condition? And exploring their background and belief system. So for example, on one end of the spectrum, we might have a patient that says, I don't know why I'm here. My doctor just said I had to come. And that's very different than a patient who perhaps spent all weekend researching a certain condition or the reason that they came through to you. So it's important to really tailor the sessions to meet the patients where they're at. So for example, some phrases we might have include, I've reviewed the records from your doctor, but can you tell me in your own words what you've heard so far? Or we will be going through information about the options, but is there anything specific you want to make sure we cover? And then we're going to talk about these different topics. Does that sound okay to you? So a lot of emphasis on the patient and really tailoring on what the patient's needs are. Contracting is such an important tool in every capacity of genetic counseling, whether it be in a traditional clinical space, research space, non-traditional as well. It's such an important tool to meet the individual where they're at and tailor a session, a conversation, and meeting to their needs. So I think this picture really depicts the different ways that contracting can lead a session. So you might have a patient that based on their background, education, interests, goals, wants to take the green slope. They want to just build a snowman. Or you could have someone on the other edge of the spectrum that wants that double black diamond, wants to build a family of snowmen blindfolded in Miami with no hands. So it just really highlights the different positions that patients can be in. And that is our job as genetic counselors, is really to elicit that background in order to provide this information and empower the patient to make decisions. And so with that, we go to the education part of the session. So we know what the patient's goals are, we know what their background is. Now it's about educating them with the genetic information that you researched in your homework or know from your training. So some things that we think of as far as conveying for education, for decision making include features, natural history, and variability of a condition, genetic basis if it's known, how can this be diagnosed and managed. So a lot of the components that Courtney was mentioning with that Smith, Lemli, Opitz example, that homework components, those are ones you now want to educate the patient about. Also, a huge one in prenatal is chances that this will occur or recur in a family. Families that have had a prior pregnancy with X condition, they're wondering if it's going to happen again. And then really meeting the patient where they're at, their unique situation. So exploring economic, social, and psychological impacts of this diagnosis, of this information, and how that fits into the patient's picture. Finally, an important thing to make sure you do is connect the patient with available resources, whether that's a referral, specialty referral, or connection to a support group or online resources for the patient, really putting together that comprehensive picture to provide the best session, to provide the best education possible. And so an example that comes up all the time in prenatal is Down syndrome counseling. We talk to a lot of patients about the chance of having a pregnancy with Down syndrome, as that does affect all women and does go up as you get older. So meeting the patient where they're at, exploring how to differentiate what chromosomes are, how to explain the reason why Down syndrome happens from a genetic basis, so that extra copy of chromosome 21, and then painting a picture for the patient as far as what it's like to raise a child with Down syndrome and what that might look like for their family.
So another really important part of the session is gathering information about a patient's medical history as well as their family history. And this varies based on the focus of the session and also the context that this counseling is taking place. But some of the questions you may ask a patient are, have you had any major surgeries or any hospitalizations? In an adult or pediatric context, we may be asking about developmental milestones. How old was a child when they first took their first steps or when they spoke their first words? In the same context, there may be a physical examination with a geneticist or another physician to identify subtle features that may point us in the direction of what testing we might want to order. We ask about reproductive history. In prenatal, we ask specifically about pregnancy history to gather that information. And we also ask if they have any chronic health conditions, anything that they might take a medication for, or that they see a doctor or a specialist about routinely. And like I said, some of these questions may be more pointed in certain areas. Like I mentioned, for adult or peds, we ask more about developmental milestones, and the physical examination is a big portion of that visit. But say in maybe a cancer or oncology setting, asking about personal diagnoses of history or diagnoses of cancer or history in family members is equally important. And so when we ask about family history, we're often doing this in the form of taking a pedigree, which is a great tool for genetic counselors in gathering information, and is something that we train to take in graduate school and become very good at. Mm-hmm. And so essentially a pedigree is a 3-generation family tree, and we use symbols, a square for males, a circle for females, and relationship lines between those individuals to show how people are related to one another. And we ask questions about the health of those family members with the goal of identifying any patterns that may be showing up in the family history. And based on those patterns, speculate what the chance of our patient or their child or another family member developing similar things. And so a lot of the times we're hoping for something to have a clear inheritance pattern like we see in this pedigree here that's showing X-linked recessive inheritance, where you can see that there are affected males coming from carrier females and it's passing through a family with multiple affected family members. But a lot of times it's not that straightforward. So usually our pedigrees look a little bit more like this. So there's a little bit of more complicated factors here. A lot of individuals have health concerns that are very common in the general population and may not be associated with a single gene change, but rather a combination of multiple genes in the environment. And you can also see some more complicated relationships such as twins, or someone who's adopted, or someone who's experienced infertility. Things like that are showed in this family history. And so when we're looking at this, it's also a great way to provide resources to patients that may not be in the form of genetic testing, but perhaps a referral to a specialist based on a family health history, or bringing this to the attention of the patient so that they're more likely to bring it up with their general provider, their family physician, so that they're aware of it and can get appropriate screening. And so after we gather all this information, whether it's through the results of genetic tests, our medical record review, asking about their medical history and their family history, we provide a risk assessment, which is a very important part of a session. And essentially taking all of that information, it's providing either in words like high risk or low risk, or in a numerical risk like 1 in 4 or 1 in 10, to a patient that gives them an idea about what the chance or the likelihood of them developing a certain genetic condition, or their pregnancy, or a family member. In a lot of the times this involves some basic math, is working with probabilities, but the next step is communicating that in a way to a patient that's understandable. So a lot of the times when we say this to a patient, your risk is 1 in 100, it does not mean much unless there's a context to it. So we ask, how does this risk sound to you? Does this sound like a high risk? Are you seeing this as a low risk? How about if I say that it's 1%? Or what if there is a 99% chance for that not to happen? And all of these are the same statistic, but just said in different ways that allow us to gauge what a patient is thinking about that risk assessment. So I think that genetic counselors get very good at this in terms of presenting a statistic in multiple ways so that a patient feels empowered in their knowledge about their risks.
So we've gone through all those other components or elements of the genetic counseling session. Now we're talking about testing options. Once the patient knows they actually do want to do testing or has elected that, then we navigate a variety of different factors. So that's from the scientific factor, is this the most applicable test, to insurance considerations. Will insurance cover this testing? What's the expected out-of-pocket cost for the patient? Because that goes into patient decision making as well. And then what does a positive result mean, or what does a negative result mean? So interpreting that result component of the testing. And then, as we've highlighted through a lot of this conversation or this presentation, is going back to the patient. Not just interpreting the risks, but also what do these results mean to you? What will these results mean to you? And how will that impact their decision-making, planning, or next step process? I will note that in addition to just the patient navigating these testing options, we do provide an important resource on a healthcare team as well to help navigate the crowded market of testing options, to help understand what testing as a practice meets these criteria that I just went over. And then it's time to wrap up. So as a genetic counselor, I'm completing the necessary paperwork and consent forms. I'm planning with the patient of how I'm going to contact them regarding results. Is it going to be over the phone? Is it going to be a letter? Should the patient come back in, and we should have another conversation specific to results disclosure and review what those results mean to them, psychosocial implications. And then it's important to review the contracted plan that we made at the very beginning to make sure all the relevant points were covered and the patient feels like their questions have been answered. So some things we might mention include, we went over a lot of information today. Is there anything else you want to review again? Or how does all of this sound to you now that we've discussed it more? Patients can change how they're feeling based on our conversations. What is the most important thing to you moving forward? I think that really helps set the patient up for next steps, including when they get those results back. And so I think this graph really highlights beautifully what it can be like in a genetic counseling session, how you've done your homework, you have your plan, you have your goal, but in reality, once the patient walks through the room and you're having those good contracting conversations, going through the education component, talking about risks, in reality, it just can go so many different directions. And that's why genetic counselors really are so good at being very flexible to the needs of the patient, the needs of the session, but it really can go absolutely all over the place. But still, we're meeting that goal of informing the patient, helping them make important decisions for their own healthcare.
So today we highlighted those main aspects of a genetic counseling session and the goals of those sessions. But I also wanted to provide you with some additional resources in case you're interested in learning more about what happens in a genetic counseling session. So the National Society of Genetic Counselors puts out this Master Genetic Counselor series that's very good and a great resource. And as well as YouTube, there's the option to see genetic counselors presenting at conferences or also talking about what happens in these genetic counseling sessions. And in addition to this, I also put a podcast called DNA Today that's run by a genetic counselor, as well as the DNA Exchange, which is a forum where genetic counselors can write blog posts about the field of genetic counseling. And these are both great ways to stay up to date with what's happening in the field and what genetic counselors are saying. So we hope you enjoyed this, and we thank you for joining us for Brigham Career Day. But we would also encourage you to join us live on Monday, July 20th for our live sessions. We look forward to seeing you then.